everyone. My name is Professor Jema Brown-Kishbaugh. I am an endocrinology nurse practitioner, and Dr. Minter had asked me to talk to you about endocrinology, my specialty. So when we're talking about the endocrinology system, it is a group of glands that maintain body homeostasis, and these glands are located throughout the body. They are not in just one area. What we use are hormones to relay messages from the hypothalamus to the anterior pituitary and then to the target endocrine gland. Then we allow more hormones to be released and then go to the target tissue. We use feedback signaling to control or inhibit the release. And as you can see here, we have negative feedback as well as positive feedback. Positive feedback basically is going to elicit a response in the positive, meaning something is going to be a mechanism of action from that. If it's a negative feedback, it is going to inhibit the release of something, whether it be a signaling hormone or the actual hormone that is going to elicit a response at the target tissue. Basically, the hypothalamus is the master gland that is located behind the optic chiasm in the brain. Hormones that come down to the anterior pituitary. The anterior pituitary houses most of our hormones, and then that will go to a target endocrine gland, such as thyroid or the adrenal glands or the gonads. Endocrine is highly involved with the reproductive and as well as the neurosystems. They're all integrated. Once we get to the target endocrine gland, then we elicit hormones from that target tissue and from that target endocrine gland, and then they go to target tissues wherever that may be throughout the body. Endocrine is in charge of metabolism, growth, development, and reproduction. Hormones, just brief, there are specific rates and releases of secretion. Random hormone levels really do not give us much information, and when we are testing these levels, they need to be at certain times of the day. Hormones follow circadian and diurnal rhythms, and they are released at certain times, and that is, we need to measure those to necessitate a diagnosis. We operate within those feedback systems with hormonal control. When the hormones are released, they will only work on the effector receptors, and then there are only certain functions or activations within that target cell. Free hormones can activate changes at the targets. Hormones are actually highly protein bound. Albumin is a big one, and there are other specific ones such as sex hormone binding globulin or thyroglobulin binding hormone. All of those things are highly specific for the job, but they are highly protein bound to get from the glands. We classify the hormones by structure, gland of origin, effects, or chemical composition. We have steroid hormones, we have peptide hormones, and really it's based on what they're made of. The hormone release is a response to an alteration in the cellular environment or a process of regulation of those hormones, and that would be those feedback systems, that regulation. Response to an alteration in the cellular environment, think blood glucose, sodium, potassium. Those would all be things that would elicit responses from our hormonal system. There's a couple of mechanisms by which the hormones respond. Endocrine is basically the same cell, so you would have, let's say, cell to cell. So you would have a cell, it releases, and it basically is going to impact something within that same cell. That is an endocrine mechanism. Paracrine, this would be neighboring cells or in the region. So this could be the anterior, the hypothal, down to the pituitary. That's within the same region, okay? And then endocrine, this is where we get the name from. Endocrine basically is circulating hormones. They're released into the blood and transported through the body. You gotta have blood transport, all right? It goes from point A to point B through the vasculature. Laws of endocrinology are a little different. So if we are trying to test for hyposecretion of a hormone, we have to try and stimulate it. When we talk about those feedbacks, there are multiple layers of hormones coming out, and we have to actually pull most of those hormones. And then when we try to stimulate it, we will see where the defunct is. Is it a primary issue or is it a secondary issue related to how they are stimulated in response to, let's say, an ACTH stimulation test. If we are looking for hypersecretion, we're going to try and suppress it. So we would be trying to turn off and do a negative feedback. So when we talk here trying to stimulate it, Is the target organ working? Is kind of what we're looking for. If we are trying to test to suppress it, is the feedback system working? And that is what we look at. And like I said earlier, random hormone levels are not helpful. Many are pulsatile, follow circadian rhythms, etc. So just a brief review of the anatomy and physiology. Where is everything located? So here is your hypothalamus. Right below it is the pituitary gland. The pineal gland is the epiphysis. It is involved in the endocrine system, but we really don't talk about it too much. There's not really many abnormalities that come with that. So that is all basically right behind the optic chiasm in the brain. Your thyroid gland and parathyroid, the adrenal, your pancreas has endocrine features in addition to the exocrine features of it. Ovaries, testicles would be the gonads. And then other endocrine functions are present with brain, heart, liver, GI, and fat, but we don't consider that part of the endocrine system. We just know that there is endocrine functions involved with all of those. So here's a look at what happens in the hypothalamus down to the pituitary. We have internal and external stimuli that is received not only from the efferent pathways from the external situation, but then also internal, such as chemical changes and the feedback system. Neurotransmitters are involved, so there are neurostimulus that comes down to the hypothalamus, and then we get releasing hormones from the hypothalamus. The hypothalamus goes mostly into the anterior pituitary. That's where we get most of our hormones. Your posterior pituitary basically has antidiuretic hormone and oxytocin, and you can see where the effects are. So ADH and oxytocin are actually made in the hypothalamus and then transported the way down. The releasing hormones for the anterior pituitary are actually stimulatory, and then the hormone is synthesized down here to get these different hormones. Growth hormone, which is going to stimulate bone and soft tissue growth. We have ACTH, which is adrenocorticotropin hormone, which is going to stimulate the adrenal gland. We have thyroid stimulating hormone, which is going to stimulate the thyroid gland. We have FSH and LH, which are follicle stimulating hormone and luteinizing hormone, and those will go to both the testes in the male, ovary in the female, and stimulate its resultant testosterone, estrogen, or progesterone. And then prolactin to stimulate breast milk and enlargement secondary to pregnancy. Here's another picture of the posterior and anterior pituitary. This is a nice classification here, so you can see what's coming out of the anterior pituitary: TSH, ACTH, LH, FSH, growth hormone, and prolactin. What happens from the hypothalamus to the pituitary is we have releasing hormones. So corticotropin releasing hormone, thyrotropin releasing hormone, gonadotropin releasing hormone, growth hormone releasing hormone, prolactin inhibitory hormone, and then melatonin secreting hormone. Those are all the ones that come down. So then the pituitary controls the release as it's delineated there. One of the big things that happens with the pituitary gland is a pituitary adenoma. It's the third most common in a cranial neoplasm. It's usually benign, but what we get concerned with is related to all those hormones. Is it functioning or non-functioning, and what is the size? If it's non-functioning, then we get concerned with size because it can present with signs and symptoms that are consistent with mass effect. And that is related to the compression of the optic chiasm. Right where that pituitary sits basically compresses the pituitary stalk, and then that can lead to hypopituitaryism. Now, if it's functioning, that would be dependent on which hormone is secreted or produced. Treatment would be to manage the hypo or hypersecretion of whatever hormone is functioning, and then also manage the size of the adenoma by surveillance and surgical removal. Next up is the thyroid gland. So the thyroid gland, butterfly shape, that sits in the neck. So hypothalamus to pituitary is thyrotropin releasing hormone, and then from the pituitary to the thyroid gland is thyroid stimulating hormone. Negative feedback system turns off pituitary in addition to hypothalamus. The positive is T3, T4, and calcitonin. T4 to T3 basically gets converted. These would be your target tissues. So we have liver, so we have cholesterol, as well as gluconeogenesis, so will increase glucose levels. We also have fat oxidation and synthesis, and that's where we get our increased cholesterol synthesis. We also fatty acid mobilize, meaning that we can have more adiposity. For the cardiac, there are lots of TSH receptors, thyroid receptors on the heart, so you will have increased heart rate. For the growth hormone, TSH production actually increases growth hormone, inverse relationship. And then once we get down to skeletal muscle, that is where you're going to see increased protein catabolism, muscle oxidation, glucose utilization, fat oxidation. And then when we're talking about thyroid on effects on the bones, growth, maturation, and reabsorption. So the two main things that happen are hyper and hypothyroidism. So hyperthyroidism is an overactive thyroid gland, produces increased amounts of circulating T3 and T4. It basically increases all those metabolic processes, and that is due to an increased synthesis of the sodium potassium adipase. There is an increased sympathetic response, and that is because of expression of beta adrenergic receptors. Three main mechanisms: Graves' disease, multinodular goiter, and thyroiditis. Basically, your metabolism goes into overdrive. You can have a severe fatal thyroid storm if left untreated. Depending on what the cause is, the treatment would vary. Let's take a look at hypothyroidism. So this is an underactive stimulation and release of hormones from the thyroid gland. So basically, you're not going to get T3 and T4. Decreased metabolic rate, decreased sympathetic nervous system stimulation, everything slows down. Etiology, iodine deficiency, which is rare in our country, but if you would have patients from other countries, it would definitely be a causation. Hashimoto's thyroiditis is the #1 cause, and that's autoimmune. Medications such as lithium, amiodarone can cause it. They may have had to have surgery related to Graves' disease or radioactive ablation, and that can result in a subsequent hypothyroidism because they have ablated the tissue. You can also have a fatal hypothyroidism called myxedema coma. Left untreated, it is fatal. So here's Hashimoto's. So this is autoimmune destruction of the thyroid gland. This is the #1 reason that you get hypothyroidism. It is autoimmune. So where iodine sufficient is the most common cause, it's autoimmune. If it comes from somewhere that is underdeveloped or non-industrialized, iodine may be the cause. Ends up with follicular damage. You have antithyroid globulin, antithyroid peroxidase antibodies, and this is basically what it looks like. So we have CD8 cytotoxic T cells, CD4 activated macrophages, basically goes in and injures the thyroid cells. And then we have antibodies that end up with cytotoxicity, the breakdown of the thyroid tissue. You require levothyroxine replacement therapy, which is basically T4. So we are just giving it to you back again because your thyroid gland is not producing it. Graves' disease is the hyperthyroid most common cause. So this is also autoimmune. In endocrine world, autoimmune diseases are heavily prevalent. So this is autoantibody stimulated receptor hypersensitivity. So basically what happens is you have an antibody, it goes to the TSH receptor within the thyroid tissue and basically stimulates hormone synthesis. You have unregulated overproduction of thyroid hormones. Leads to increased synthesis. You can have a diffuse goiter because we are getting some hyperplasia and hypertrophy related to that activation. Again, thyroid storm, potentially fatal complication. We would antithyroid, so we would turn it off by giving antithyroid medication, surgery, or we would ablate the tissue. Next up is the endocrine pancreas. So 3 mechanisms. Basically, we're targeting the islet of the Langerhans, and that's what they look like up here. Many cell types producing different hormones. Insulin beta cells are usually in the circle part of the islet of the Langerhans, and they obviously regulate insulin in response to glucose. Then we have glucagon, which is on the outer part of the islets, opposes insulin in order to increase blood sugar in times of fasting. The 2 main processes that we talk about with the pancreas is type 1 and type 2 diabetes. They are completely different pathways, so understanding the difference is one is insulin deficiency, and this is autoimmune, again, destruction of the islet cells by T lymphocytes. We would be able to test by antibodies as a sign of damage, and then that would lead us to type 1 diagnosis. If untreated, can be fatal. Diabetic ketoacidosis. They basically have no insulin production. So without insulin, you turn over to fat metabolic action, and that creates ketone bodies and creates a metabolic acidosis, which is what you die from. So we need insulin therapy, life-sustaining. Severe illness or misdosing can lead to DKA. Type 2 diabetes, so this is the two mechanisms here, insulin resistance and then decreased insulin production. Usually have components of that, and that's what this is here. So we also have obesity, inheritance, other factors, environment, all leading to this insulin resistance. The muscle is unable to take the glucose up. It gets stuck in the vasculature, leading to hyperglycemia. The pancreas cannot overcome the hyperglycemia. This is your classic middle-aged obese. We are starting to see it in our younger population due to the epidemic of obesity. We have multiple medications, oral, injectables, and insulin therapy. All depends on how advanced and uncontrolled you are. So we talk about this ominous octet with type 2 diabetes. And this is why we have multiple medication classes that are available. So the ominous octet are about 8 reasons why diabetes type 2 is happening in our patients. And then the medications are over here listed. Decreased insulin secretion, we would use a sulfonylurea such as glipizide or a TZD such as Actos. And this basically increases insulin secretion from the remaining islet cells. Decreased incretin effect, this happens in the gut. This is something that is related to an abnormal way that they metabolize their carbohydrates. The GLP-1 such as Trulicity or Ozempic works on improving the incretin effect. TZDs also work on lipolysis and help diminish that response. Increased glucose reabsorption. So the drugs that are new here are actually the SGLT2s, such as Jardiance. So that would be SGLT2s. So they actually lower the reabsorption rate and have you urinate out more sugar. So decreased glucose uptake, TZDs work here, as well as metformin, with making sure that the muscle cells take up more sugar. Neurotransmitter dysfunction, this a lot is related to, again, on the incretin system. GLPs work on this as well. Increased hepatic glucose production, TZDs, which would be Actos, as well as metformin, work here. Increased glucagon secretion, GLPs work on that and calm that down so that we decrease the hepatic glucose that comes out. So those are just a brief kind of overview of where all of the meds that we utilize in type 2 diabetes are working. And that's why your patient may or may not have 1 to 5 different mechanisms to try and control their diabetes. So the American Diabetic Association has targets less than 7.5, depending on your comorbidities as well as your age. Those are things that we determine in a case-by-case situation. Here are just some examples of less stringent goals, such as very young, older, and then a history of severe hypoglycemia. We liberalize our targets.